Hello everyone, welcome back to my channel. Hope you all are doing well and studying well. Let's continue today with hepatobiliary disorders. Liver. Liver is an important organ in our human body. In liver, bilirubin metabolism and bile formation takes place. This unconjugated bilirubin, which is an end product of the heme degradation, which is lipid soluble and water insoluble. This makes it more toxic to the brain in the newborns. Now, the heme. The heme, which gets converted into biliverdin in the presence of an enzyme known as heme oxygenase, and this biliverdin gets converted into bilirubin in the presence of an enzyme known as biliverdin reductase. This undergoes reverse binding to the serum albumin, which then transported into the liver. Coming to the detailed mechanism, here as we can see the normal RBCs whose lifespan is around 120 days. After 120 days, they become senescent RBCs. These senescent RBCs, along with 15% bone marrow, immature RBCs, myoglobin, extraepithyroid or erythropoiesis, this gives hemoglobin. This hemoglobin is degraded into globin and heme. This globin gets into the protein pool. This heme, as I mentioned, gets converted into bilirubin in the presence of these two enzymes. Now, this bilirubin is transported into the blood where it gets binding, that is reverse binding with the albumin to form unconjugated bilirubin. Now this unconjugated bilirubin is transported to the liver where it gets conjugated in the presence of glucuronidase. This conjugated bilirubin now is excreted as conjugated bilirubin in the duodenum, where this duodenum, in duodenum, 20% of urobilinogen is formed in the intestine, and this 20% is reabsorbed in the intestine. This urobilinogen comes to the kidney where it is excreted through the urine. Now the another part of conjugated bilirubin is converted into urobilinogen in the intestine. Now this 80% is excreted as a stercobilinogen. Then this stercobilinogen in stercobilin, which gives the dark color to the stools. Note, there is an important disorder that is kernicterus. This kernicterus is irreversible brain injury due to the high concentration of free unconjugated bilirubin which crosses the blood-brain barrier. This takes place in the small children. What are hepatic stellate cells, which are also known as ito cells? These hepatic stellate cells are found in the space of the disk. These are high in lipid content. They store vitamin A. They synthesize extracellular collagen. Jaundice. As we all know, the important topic is jaundice. What is jaundice? Jaundice is an yellowish pigmentation of the skin, mucous membrane, sclera due to the increased level of bilirubin. As we know, the normal bilirubin is 0.3 to 1.2 mg per dl. If the increased levels are 2 to 2.5 mg per dl, it is considered as jaundice. Now coming to types, there are two types. The two types, if it can be differentiated as underlying cause, it may be unconjugated and conjugated. Coming to pathological, it may be hemolytic jaundice, hepatocellular or obstructive jaundice. Now coming to hereditary hyperbilirubinemias, there are certain disorders under this category. For the first is Crigler-Najjar syndrome. In this, we can see there is impaired conjugation of the bilirubin. It is an autosomal recessive. There will be a presence of an enzyme known as UGT1A1. This is UDP glucuronide transferase. In this chronic, it may be severe unconjugated bilirubin, which leads to severe jaundice and it may lead to death. The treatment is phenobarbital. Phenobarbital may be given to this kind of patients. Type 2. In this type 2, it is less severe. Partial deficiency of UGT1A1 enzyme is present and it is autosomal dominant. Remember, type 1 is autosomal recessive, type 2 is autosomal dominant. Now coming to Gilbert syndrome. In this Gilbert syndrome, we can see the mutation in the UGT1 gene and it is also autosomal recessive. This mutation leads to inadequate synthesis of UGT1A1 enzyme. It is less severe than the Crigler-Najjar syndrome. It is mild, chronic, and unconjugated functioning hyperbilirubinemia. Now coming to Dubin-Johnson syndrome. In this, liver is darkly pigmented due to melanin-like granules of epinephrine metabolites. It is also autosomal recessive. There is complete absence of a multi-drug resistance protein 2. It is known as MRP2. This protein mediates the transport of conjugated bilirubin across the membrane into the bile. This is the main important function of this protein known as MRP2, and complete absence of this MRP2 leads to Dubin-Johnson syndrome. Now coming to Rotar syndrome. In this Rotar syndrome, it is a rare form of conjugated hyperbilirubinemia. It is autosomal recessive. Liver morphology is normal in this case. Now, let's continue our discussion with viral hepatitis. These viral hepatitis, the viral infection of the hepatocytes that produce necrosis and inflammation of the liver. Hepatitis A and E, which cause acute hepatitis. Hepatitis B, C, D causes chronic hepatitis. Now coming to hepatitis A virus, this is maximally infectious just before the onset of the jaundice. The main is a fecal-oral route. It is benign, self-limited acute hepatitis. There will be increased serum ALT and AST, increased bilirubin. Serum ALP will be less than 300 international units per liter. IgM anti-HAV indicates the infection. IgG anti-HAV indicates recovery or vaccination. Now, coming to hepatitis B. Hepatitis B, it is hepatotropic DNA virus. The genome will be 4 genes, that is HBsAg, HBcAg, HBV polymerase, HBxAg. This HBV is 100 times infectious as HIV and 10 times as HCV virus. Remember this important note. Now coming to mode of transmission. The mode of transmission may be vertical or congenital transmission, and the second is horizontal transmission. The transmission can be remembered by the mnemonic 4Bs. The 4Bs are B for blood, B for birth, B for blood bank, and B for body fluids. Remember, this hepatitis B is not transmitted by breastfeeding. This is also B. So remember, it is not transmitted by breastfeeding. What are the outcomes of the HBV infection? The outcomes may be acute hepatitis, chronic hepatitis, cirrhosis, or fulminant hepatitis with massive liver necrosis or hepatocellular carcinomas. The serological markers are HBsAg, persistent after 6 months. This may lead to chronic HBV. It is the first virological marker. Anti-HBs, it is a protective antibody which develops after recovery or immunization, which may be detectable in the serum after the disavailability of HBsAg. HBcAg, HBV DNA, and DNA polymerase. In this, HBcAg, HBV DNA are the infective particles of the HBV. The valuable in assessing prognosis, it is indicate active viral replication. HBcAg or HBV DNA, this is after 6 weeks of onset. Infective and chronic hepatitis never appears in the blood. Now coming to anti-HBC, in this IgM anti-HBC, which are earliest antibody markers. It indicates recurrent infection. IgG anti-HBC, remote infection, indicates previous infection with the HBV. Now coming to hepatitis C virus, in this we can see it is mainly RNA virus. The previous one was DNA virus. The outcomes are acute hepatitis, chronic hepatitis, cirrhosis, fulminant hepatic failure is rare. Next, the hepatitis D virus. The hepatitis D virus, it is mainly of a parental route or sexual contact. This hepatitis D virus can be remembered by 3Ds. These 3Ds are delta agent, defective virus, and it is depends on HBV. It is defective RNA virus. Now, coming to HDV virus infection. It may be co-infection of HBV and HDV, superinfection with HDV in chronic HBs age carrier. The serological marker in this case are HDV RNA anti-HDV. Now the next is hepatitis E virus. In this hepatitis E virus, it is mainly zoonotic disease with animal reservoir. It is high mortality rate among pregnant women. It causes self-limiting acute hepatitis. The three E's remember here are endemic in equatorial regions, epidemic frequent, and expect mother high mortality rate. This acute hepatitis incubation period, symptomatic pre-icteric phase, symptomatic icteric phase, and convalescence phase. These are the four phases of this acute hepatitis. There is an important note to remember. Aminotransferase levels peak before the appearance of the jaundice. Serum ALT is the last enzyme to return to the normal. So, the summary of the above mentioned hepatitis are types of the virus, ssRNA, fecal-oral route of transmission, mean incubation period is 2 to 4 weeks, frequency of chronic liver disease, it will be never, diagnosis is IgM anti-HAV, partial double-stranded, parental or sexual contact or perinatal 1 to 4 months, 10% HBs AG or anti-HB. Single stranded RNA, it is parental route 7 to 8 weeks, 80%. Circular defective ssRNA, parental same as HBV. Then single stranded RNA, fecal-oral route 5 to 4 weeks, and it is never frequency. Okay. There is an important note. The less common cause of viral hepatitis are cytomegalovirus and Epstein-Barr virus. The rare causes are herpes simplex virus or yellow fever. Now coming to morphology, HBs AG, it is responsible for ground glass hepatocytes, that is HBV infected liver cells having finely granular cytoplasm packed with spares and tubules of the HBs AG. Coming to microscopy, the hepatocytes injury, ballooning degeneration, which is swelling, hepatocyte necrosis, and bridging necrosis. These are the important features of the microscopy of this hepatocyte injury. We can see the presence of councilman bodies in this case. Now, the inflammation, it may be mononuclear inflammatory cells or lobular hepatitis. Kupffer cells may be present or lobular ciliary. As I mentioned about, the microscopic features of this acute hepatitis show there is presence of apoptosis and terminal hepatic venules, the central vein. The aggregates of macrophages can be seen, and there is presence of a cholestasis. Then we can see the portal tract, it is infiltrated by the lymphocytes. Hepatic artery is also infiltrated. Now coming to chronic hepatitis, this chronic hepatitis, it is symptomatic biochemical serological evidence of the hepatic disease which shows more than 6 months. Hence, it indicates chronic hepatitis. The causes may be virus B, C, and D. Others are autoimmune hepatitis, drug-induced hepatitis, Wilson's disease, and cryptogenic hepatitis. Now coming to morphology, first gross. In early stages, it will be normal, and in later, it forms firm. It becomes firm as it increases in fibrosis. This fibrosis may lead to macronodular cirrhosis. Coming to microscopy of this chronic, it indicates portal inflammation where there will be presence of lymphocytes, macrophages, and plasma cells. In interface hepatitis, there is spillover of the infiltrated cells from the portal tract into the adjacent parenchyma. Parenchyma inflammation and necrosis, there is presence of fibrosis, which is the hallmark of the chronic liver disease. Clinical features may be, the patient may come with fatigue, malaise, loss of appetite. The consequence, continued loss may lead to cirrhosis, post-necrotic cirrhosis, which leads to macronodular, which is a mixed macro and micro. nodular. These are the microscopic features of chronic hepatitis. As we can see, there is interface hepatitis, inflammatory cells spilled into the adjacent liver parenchyma. And coming to diagrammatic, we can see there is periportal fibrosis, the lymphoid aggregates in the portal tract which spill into the parenchyma. Now, the next topic is alcoholic liver disease. In alcoholic liver disease, it can lead to three stages, that is hepatic steatosis, alcoholic hepatitis, and alcoholic cirrhosis. The risk factor of these diseases are: first, gender, the females are mostly affected; ethnicity, genetic factors, associated conditions, amount and duration of the alcohol intake. Now coming to the pathogenesis. Now, coming to the mechanism of liver injury by the ethanol. Ethanol, as I mentioned above, it gets converted into acetaldehyde, highly reactive and toxic component. Metabolism of alcohol in the liver by CYP2E1 enzyme. Then, reactive O2 species. Then, lipid peroxidation of the cell membrane. Next, the increased redox reaction. Due to decreased NAD and increased NADH, there will be an inhibition of the oxidation of the fatty acids. This inhibition of oxidation of fatty acids leads to the accumulation of the fat, which causes the lactic acidosis. Then, this accumulation of the fat may cause mitochondrial dysfunction due to the depletion of the glutathione enzyme. There will be increased in the production of the pro-inflammatory cytokines. Alcoholic cirrhosis, in which the function of the proteasome is impaired. This leads to inefficient degradation of the ubiquitin. This leads to increase in the accumulation of the hepatocytes in the form of the Mallory bodies. Remember the important Mallory bodies. Then we can see there will be reduced levels of ADH and ALDH isoenzymes. Now coming to mechanism of fibrosis or cirrhosis. The first mechanism is that there will be activation of the stellate cells. This activation of the stellate cells, alcohol is more important in this activation. This activation leads to transforms into highly fibrogenic cells with myofibroblast like contractile property. This produces collagen. This collagen is responsible for the fibrosis. Causes for this mechanism are cytokine C and chemokine, inflammatory cytokines like TNF, IL-1B, lymphotoxins, oxidative stress. In hepatic steatosis, it may be microvascular, vesicular, macrovesicular, no inflammation or no fibrosis. Alcoholic hepatitis, in this there will be ballooning degeneration of the hepatocytes. Mallory bodies are present. What are these Mallory bodies? These Mallory bodies are tanged skins of cytokeratin intermediates filaments in the cytochrome in the chromosome 8 and 18. There will be neutrophil infiltration, alcoholic steatofibrosis. As in microscopy, we can see there is a ballooning of the hepatocytes. As we can see, there is a ballooning of these hepatocytes. There is presence of these Mallory bodies and there is fatty change, and we can see neutrophilic infiltration also. In diagrammatic representation also we can see there is ballooning of the hepatocytes, portal tract with the lymphocytes we can see, there is fatty change, Mallory bodies are present. This pinkish extracellular are known as Mallory bodies. There is perivenular fibrosis also we can see. The important is neutrophilic infiltration also we can see. The important note here is the Mallory bodies. These are seen in alcoholic hepatitis, non-alcoholic fatty liver disease, primary biliary cirrhosis, Wilson's disease, chronic cholestasis syndrome, and hepatocellular tremors. Now, what is alcoholic cirrhosis? The alcoholic cirrhosis, the main features we can see here are loss of architecture, fibrosis, regenerating nodules, and here we can see AST or by ALT, the ratio must be less than 2. It indicates that there is increased gamma glutamyl transpeptidase, there is hyperbilirubinemia, there is increased ALP and anemia. So we will stop here. We will continue the remaining part in the next. Okay, please like, share, subscribe to our channel, and please wait for our next video. It will be uploaded